Okay, I don't have any conflicts of interest to declare. So I feel very lucky to work in the Irish Blood Transfusion Service today. You can see this wonderful team of happy scientists here behind me I should say, and there's lots of other people who are too shy to have their photographs shown today. But these are the people that generate, record and manage the data that I'll present to you today. We have a great facility at the National Blood Centre, and some of you may have visited yesterday. I believe we had visitors from Malta. We're lucky enough to have state-of-the-art instruments and assays with which to screen the Irish blood supply. But of course, it wasn't always that simple. Just over 20 years ago, we had to fly our samples to Scotland for hepatitis C and later HIV RNA screening. Now, of course, we do all that ourselves now, and we recently, or back in 2009, we actually switched to individual donation nucleic acid testing. Over time, we've increased our repertoire of testing such that now, by screening by ID-NAT, we know we're applying the best test we can to every single donation, and we don't take that for granted. We're very lucky that we don't have to pool our samples like some larger blood services have to, apologies, for cost efficiency purposes. So I've committed a little bit of an offence here, which hopefully you'll forgive me for, in that I've combined United States historical recipient infection data on the y-axis with a timeline for the introduction of the screening of various serological and NAT assays at the IBTS on the x-axis. Now, most countries would have had similar timelines and infection rates as these, but the point to make is, I suppose, when looking at the red line, the dramatic effect that testing with various serological markers has had on recipient infection rates over the last 40 years or so, or even longer, starting with screening for syphilis all the way back in the 50s, later in the 70s, looking for the Australia antigen representing hepatitis B, of course, later syphilis antibody, and working all the way through the serology assays over to the right-hand side of the slide, where we had nucleic acid screening tests available to us. So we've really closed the gap now and reduced the risk of transfusion-transmitted infection to a very low level, certainly in the developed world. So just to remind those of you who aren't aware, because I know we've many attendees here outside of the Irish Blood Transfusion Service, these are the markers that we're screening for today and will form the basis of my talk essentially. So on the serological side, we use chemiluminescent assays to screen for antibody to HIV, hepatitis C, HTLV, hepatitis B core with the asterisks because not all blood services screen for hep B core. We also screen for antibodies to T pallidum. About 80% of our donors are screened for antibody to CMV, IgG, and hep B, then surface antigen finally. On the nucleic acid testing side then, we have a triplex assay screening for the three big bloodbornes, HIV, hep B, and hep C. We also screen separately for hepatitis E virus, which I'll talk about later, and then depending on the time of year and the travel history of the donor, we screen for West Nile virus individually as well. So despite this highly sensitive testing strategy, we know that the virus has the advantage in the window period phase, which is the early phase of the detection when our assays may not be able to detect a low concentration of a pathogen. So if we take hepatitis B, for example, and accept the estimate that the probability of just one viral particle being infectious at about 18.7%, that translates for a recipient into a transmission rate of 98% when you think about a red cell unit with 20 mils of plasma from a donor with a really low viral load. Now that would be screened, say, in a mini pool of 8. And the reason why the transmission rate is so high is that the probability of a reactive result at this level is only 2%, or estimated to be 2% in a mini pool of 8. And even for individual donation or singleton testing, it's just 25%. So that's why, in combination with testing, careful selection of donors, education and self-exclusion of donors is so important in ensuring as much as possible that we don't collect a donation from a donor who's been infected recently. And that's why we would always say, look, don't donate if you think you might be at risk. So when we talk about residual risk then, we're talking about the probability of a potentially infectious window period donation being released into the blood supply. Now we do modelling to estimate these risks, and you'll be glad to know I don't have enough time to go into the model, so I'll just cut straight to the results. And that is that the risk is really, really low. Somewhere between once in every 35 years we would expect to see a Hep B window period donation. For hepatitis C, as much as every 100 years, with HIV somewhere in between. So it's just, you know, these risks are really low, but it's still really important that recipients are aware of these risks, and there is a national patient information leaflet available in this regard. So despite this really low risk and the excellent safe returning donors that we have, who contribute to about 90% of our donations every day, we did have a hepatitis B transmission in 2016, as some of you will know, and this was linked to a compliant donor who is in that window period, proving, unfortunately, that the residual risk is real and that zero risk is just not attainable. We couldn't actually identify even the risk in the donor for hepatitis B acquisition, and that's often the case. So it was still very much a puzzle for us. And even when the manufacturer interrogated the assay with the very infecting strain that caused the transmission, the assay actually performed really, really well and detected the virus down to a concentration even lower than what we would actually expect. So it's just to make the point, I suppose, that every transfusion really, you know, needs to be prescribed as indicated. I had a little purple box there that isn't popping in for me. And it's just really important as well that recipients are aware of the risk prior to transfusion. So the recipient's the most important person in this story, and just remember the recipient bears all the risk of transfusion. Now, she did receive many life-saving blood transfusions, as you can see here in the slide on the left. Particularly in the early phase of her disseminated intravascular coagulation. Her Hep B diagnosis detection is summarized on the right there. Thankfully, we were able to detect and treat hepatitis B prior to any harm or hepatitis becoming apparent, probably because she was so immunosuppressed. But that doesn't negate the seriousness of this case for us and for the recipient at that time. There it is. Okay, so on to more general donor infectious disease epidemiology then. And this series of tables here, thanks to Dervla Butler and Lisa Burke, it doesn't make for very exciting viewing because there's lots of zeros in there, and that's exactly the way we like it. So we do have really low rates of transfusion transmissible infections observed in Irish blood donors. We had a bit of a blip there in 2017 where we observed more HIV infections than we normally would. That's probably down to a change in donor selection guidelines in the previous 12 months. So far this year, we've just seen a couple of cases of hepatitis C and 3 cases of syphilis infection. Now, I should actually tell you that for one of those cases, the donor wasn't compliant with the guidelines and didn't disclose that the person didn't disclose that they actually had syphilis recently and they were treated recently. So that was unfortunate, but we caught it, so that's okay. So how do we perform, I suppose, on the world stage in terms of international comparison? Well, as you would expect, we're right in the zone of high-income countries in terms of the proportion of our donations that are repeat reactive for screening results. So somewhere between 0.003% for HIV up to 0.05% for syphilis. So the next few slides, I've picked out some items which may be of interest for you to know about donor infectious disease epidemiology in Ireland. And the first thing is that we take a sample without a donation from donors born outside Ireland and the UK. And the main reason we do this is hopefully clear from these graphs here. So you can see in the red line in the top 2 graphs and the purple line in the bottom 2 graphs representing hepatitis B and C NAT on the top, and then syphilis and Hep B core on the bottom, is that we see a much higher rate of these infections in the donors born outside Ireland and the UK by a factor of about 100. So it kind of makes sense for us to collect a sample on the first attendance, and then if donors are cleared, they're obviously welcome to come back. The vast majority of these donors have no issues at all, and then if if they've infections, then they can actually be referred on and kind of treated. But I suppose the thing to note is that this isn't the case for HIV. Whereas although the numbers are really, really low overall, Irish donors actually have a higher rate per 100,000 of HIV than these donors born outside Ireland and the UK. The reason for that is probably because we're excluding donors from HIV endemic countries for other reasons, like malaria. So when we introduce a malaria antibody test, this pattern will probably change. Another interesting aspect of our donor epi is the contrast between blood donors and the national picture for the route of transmission and risk factors for sexually transmitted infections like syphilis. So here we can see in yellow on the left that the syphilis risk that we observe in blood donors is mostly observed as a heterosexual one, and I can tell you that a lot of those infections have been acquired abroad, whereas on the right we can see for the national picture that treponema pallidum infection is most commonly reported in gay and bisexual men who've sex with men, as represented in the blue bars. And that's it, as you would expect based on our current donor selection criteria. In terms of the stage of syphilis here, I suppose remembering that syphilis doesn't transmit very efficiently by blood, we have seen cases of recent or early infectious syphilis, although very small numbers over time. The thing to note here is that it can be a marker of high-risk sexual activity, and it's also a marker, and this is in blood services all around the world, that's used as a potential marker of non-compliance. So we're kind of mindful of this. Now, all donors with infectious diseases are interviewed individually, and so we just keep an eye on these things. Some of these donors would have had a diagnosis of HIV at the same time, but thankfully that is not very common. So the last thing to say in this section is about all of you, actually, because I can say that if most of you, or those of you who've been born and raised in Ireland, you probably don't have immunity to CMV. So we can see in the top 3 bars there that only 26% of our donors overall have evidence of CMV IgG. And when you contrast that, I'm careful not to use the term seroprevalence. This is just the rate of positive infections that we observe, or positive IgGs that we observe. But when we compare that to the sample-only new donors born outside Ireland and the UK, you can see that there's a 50% almost rate of seropositivity there. So this is a really quirky aspect. Maybe Christian can figure this out for me, but it's a really quirky aspect of Irish donor epidemiology, and I've no doubt that the national picture is the same, and Susan Knowles has a publication demonstrating that in pregnant females in Ireland. So this is something that we want to explore further. So I'm going to change tack now and talk about hepatitis E virus. And this isn't a mandatory marker for us, but there are benefits for screening blood donors for hepatitis E. The main thing to say is that transfusion-transmitted hepatitis E can lead to death, especially in immunocompromised patients. It can also lead to people losing their organ transplants and suffering other graft loss. They can develop chronic hepatitis and even develop an incurable hepatitis E infection even if treated with ribavirin. And there are other nasty neurological and hematological side effects, particularly for people who are immunocompromised. Now you might say, and I know our finance director is sitting in the front row, why don't you pool your donations to make this more cost effective? And that's a very fair question that many blood services are trying to answer. For us, it was almost a really practical decision, because we were already screening our other bloodbornes by individual donation NAT. We're also in the comfort zone of knowing that we can detect really low level viremia as well. But it is relatively costly, and one could argue that the lower level viremic donors, that their units may not actually go on to cause any harm in the recipient, which of course will be unlike the case for HIV, hepatitis B or hepatitis C. The main argument against screening overall is that the risk of you acquiring hepatitis E from your diet is actually far greater than it is from transfusion. So the debate really continues, and most blood services will use their own national trends in epidemiology to inform their decision making in this regard. I hope our UK visitors don't mind me mentioning that it is worth saying that there have been a number of hepatitis E transmissions reported recently in the serious hazards of transfusion report, because some of these lower level viremias have escaped mini pool detection in mini pools of 16, so that is worth noting. So what about Irish blood donors then? Well, we obviously see much higher rates of hepatitis E infection than we do the other markers because donors are acquiring hepatitis E genotype 3 from their diet. Now, the graph on the right kind of shows the erratic nature of the rate of HEV viremia that we observe. But it might be of interest for you to know, I don't know if you remember that first lockdown period of the pandemic in Ireland when we were I think we weren't even allowed beyond 2 miles or something of our home, and we had to cook our own Irish breakfasts, and I think we were doing that really badly because we had the highest rate ever of hepatitis E detection in blood donors during that time. So obviously everyone was undercooking their pork sausages, or more scientifically, maybe a new batch of hepatitis E came in the food chain, I don't know, but we have to write that up. So since we started screening in 2016, we've intercepted over 200 viremic donations, which certainly some of which could have caused harm to recipients. It's nice to be able to tell you just briefly that a colleague of ours, an astute colleague, Sally Bayliss, in the Paul Ehrlich Institute, was able to identify some really interesting strains amongst Irish hepatitis E isolates, one of which was a rabbit-type hepatitis E, which is uncommonly seen, so I'm told, in those who are otherwise healthy. And she was also able to identify 2 other strains, which actually formed a new clade within the hepatitis E genotype, and potentially even a new genotype. So this was kind of as the result of collaboration that was fostered early on in the hepatitis E screening process with my colleagues who precede me. And I think it's just these kind of collaborations are really important, and it's an important part of the IBTS culture. We've been lucky to work with many organisations and research groups over the years, such as our colleagues in UCD, and you'll hear from Nicola Fletcher tomorrow in relation to hepatitis E. We've always been really well supported by the National Virus Reference Lab. We're still working, I'm glad to say, with the Health Protection Surveillance Centre. We've worked with Sanquin, Paul Ehrlich, International Society Blood Transfusion. And as we've seen from Christian's talk, so much can be learned and understood about infectious diseases when you start with a healthier population. So one of our most recent endeavours has been the investigation of blood donors for serological evidence of SARS-CoV-2 infection at first and later vaccination. And you can see, similar to Christian's talk, the rate of seropositivity for any antibody type increased from our first wave study, which was obviously a pre-vaccination study, from about 3%, but I think it was as high as 5% in our younger donors, up to a whopping 70 to 99%, depending on the antibody type you're talking about, in our most recent data set. So, I mean, this won't come as a major surprise to many of you. Many of you will have experienced this seroconversion for yourselves, but it's still nice to see. There's a really nice poster on this in the poster session from our colleagues in the Health Protection Surveillance Centre, but I just wanted to rob this slide to show you that I think these 2 intersecting lines kind of tell the story of a pandemic caused by a virus for which we're lucky enough to have a vaccine. And that is that most blood donors now, the vast majority, have evidence of natural exposure to SARS-CoV-2, and that those with vaccine-only responses in the S-positive anti-spike only line, they're very much in the minority. Now, what this means, of course, as Christian said, about our protection against Omicron and the variants to follow in the future, we don't know for sure. But I think we can certainly say that Irish donors are well protected against severe disease and hospitalisation. And it's nice to note also that those of you who have had SARS-CoV-2 infection, you probably, if you've been vaccinated as well, have higher anti-spike antibody levels, as has been shown with our blood donor data. So this has been received quite positively by the media, which is a nice, I won't say novel thing for the IBTS, but it has been a good news story for us. And we have some other studies as well, which I don't have time to go into. And you can see real live SARS-CoV-2 blood donor data on the Health Protection Surveillance Centre website. We don't always add tests in the IBTS. Sometimes we take things away and try and rationalise a little bit. My colleagues Alison Waters and Porrick Williams use modelling to inform a risk-based decision-making approach to changing from universal to selective HTLV antibody screening. And donor infectious disease epidemiology was really an important part of that. So they based this on the hypothesis that if we filter out the white cells, so technically if we're removing the virus for a really rarely observed infection in Irish donors, that this should be adequate. We shouldn't have to screen our donors every single time that they donate. So thankfully the model kind of issued a very clear-cut response, which was that it was very safe indeed for us to do this. But leukodepletion will be an important part of mitigating the risk in the future. So into the end zone now, just a couple of words or my thoughts on emerging infectious diseases. Many of you have been working in laboratories and infection services, public health, and have been dealing with emerging infections at a kind of uncomfortably increasing rate of late. And blood services have to deal with the same issues. Over the years, the IBTS has had to respond to many emerging threats, such as West Nile virus, Zika virus. Actually hidden under the mosquito there is another virus like West Nile called Husutu virus. Hepatitis E I've spoken about. SARS-CoV-2 was really more of a blood supply than a blood safety threat, but we didn't know that at the beginning, did we? And then most recently we've monkeypox, which carries a theoretical transfusion transmission risk, which is probably real, although the viremia is short and we haven't seen any TTIs yet. But there are many other viruses and parasites that we can't screen for them all. So it's really our donor selection guidelines that have to respond to these threats, and we have to remain constantly vigilant for outbreaks around the world that may affect our returning travellers, our returning donors, because Irish people really like to travel, Irish donors really like to travel. So this is a constant challenge for us. Personally, I think we need to really watch out for the ticks and the mosquitoes. Just because we live in a cold climate doesn't mean we're protected, because as I said, the donors travel, and these mosquitoes and ticks can transmit infections to donors and then on quite efficiently to recipients for many infections. So the populations of these little creatures are expanding all the time, probably aided by global warming, which, as they say, is on us. And maybe more worrying than the ticks and the mosquitoes is the human-animal interaction. Where we live, what we eat, what we breed, and how we process it, I think is really important. As we've seen with variant CJD, human immunodeficiency virus, SARS-CoV-2, that once the human chain is breached, I suppose you can't go backwards. So I think we're going to have to be really careful in that regard. We theoretically could end up in the position like we were at the beginning with the red line showing an agent contaminating the blood supply unknowingly, and we're not testing for it. But I think, as Tor always says to me, we have to try to be, Professor Tor Hervig, our medical director, we have to try to be optimistic, because with really good international and national communication, if we continue with close surveillance and horizon scanning, we should be able to keep the blood supply safe into the future. Thank you very much for listening, and I just want to name a few people who helped me with the data. Thank you very much.
Thanks very much, Niamh. Excellent talk. Perhaps I could start with a question, which is, I wonder if you could kind of comment on where you think COVID convalescent plasma is going, if there's still a role for it from the blood establishment point of view and maybe from the clinician point of view, because it seems to be coming slowly back on the agenda.
Yeah, and I didn't have time to talk about that because we were part of that. We have collected some units of convalescent plasma, and there have been obviously several studies in that regard. And I think that overall the jury has come in against convalescent plasma in terms of its benefit. But I still think there's probably one remaining question, and that's the immunocompromised patient who doesn't have any antibodies at all. So it would kind of make sense that if you infused these antibodies, maybe, at least theoretically, it should be of some benefit. And maybe there are some T-cell responses in there that could be aided as well. So I think there's one question remaining, but overall, I'm not sure. I don't think the benefit is there. But we still have a couple of units on the shelf, but what we need to do is collect convalescent plasma from those who've been infected with Omicron and obviously vaccinated as well. And then maybe we can get somewhere with closing out that question. And I know you, Alison, did a huge amount of work, as did Barry Doyle, Porrick Williams, many others, in terms of the convalescent plasma. And our lab set up the test really quickly, and we were working with the National Virus Reference Lab. So I think it was a really worthwhile exercise. But yeah, I would be on the no side at the moment anyway. Thanks for the question.
Thanks, Niamh. Any other questions there? The microphone.
Maybe. Yeah, I've got it already.
Oh, yeah.
Yeah, thanks for a very nice presentation. Just staying with the convalescent plasma, we're doing research together with the Department of Rheumatology and patients who have received rituximab, for instance, they have, of course, a very low response to vaccinations. With regard to antibodies, they still have a strong T-cell response. But I think, as you're saying, there could be special cases where it would actually be a good idea, because with convalescent plasma, we have a product which is actually, it is developing over time, and it is ready before the companies can actually provide antibodies which are directed against the new variants. So even though it is deemed dead, we also get calls from the Department of Infectious Diseases now and then who ask us for new components, even though we don't actually collect plasma anymore. Yeah, so I think that demand will keep on popping up.
Yeah, and then there's always those single cases, I think, where one clinician is kind of desperate for a patient, and that has occurred already. And I think if the product is there and it won't otherwise cause harm, you know, sometimes it's worth a shot, I suppose.
Any more questions for Niamh?
Oh, there's somebody down the back, I think.
Just, I suppose, a comment really and feedback in a complementary way in relation to the CMV, the relatively low, as you said, seropositivity rate of CMV in the donor pool. So for many years, as you well know, in the bone marrow transplant cohort, of course, CMV negativity is a very important beneficial factor to start with in your transplant and to maintain, and because of the multiple transfusions those patients receive. Historically, this was a big problem, and I remember comparatively in the 90s, even between the US, where we'd worked to the 80s and here, we had a much lower frequency, as you'll be aware of, significant CMV infection. And this predated even universal leukocyte depletion. And it's really been attributed because we've been able to, because of the low CMV seropositivity in our donor pool, effectively belt and brace, historically, every single donor unit given being CMV negative. And that's not necessarily a policy that's applicable in other jurisdictions because of the high CMV positivity. I just wondered what, A, to complement that point and to recognise the contribution of the Irish transfusion, this has been a real impact, but B, in, I suppose you mentioned in HTLV1, for example, just relying now on, as I understand it, filtration or universal leukocyte depletion. I mean, just to update very briefly on that in relation to CMV, where there are varying seropositivity rates in the donor pool.
Yeah, I mean, I'm aware of the national guideline, which would indicate that in terms of screening blood components for recipients in terms of mitigating CMV, that they're a very narrow group that should require CMV negatively screened components. And I think, you know, there's mixed thinking on that. Certainly at the moment, I suppose all I can say is that we are still screening. So we still have a result for, you know, 80% of donors who previously we'll continue to screen them if they're negative. Once the test switches to positive, then we stop screening and that donor is assigned as positive. My understanding from feedback from some colleagues is that they still wish to know the status of the blood component, particularly in the period leading up to a HSCT transplant. So I don't know if that's kind of as well the point you're alluding to, that's helpful information to have, and that some of the clinicians still wish to have that information. Yeah. So I understand the guidelines are being applied in some hospitals universally and in others on a more selective basis. Would that be fair to say? Yeah.
Thanks very much, Niamh. Just in the interest of time, we're going to finish up there, but thank you very much.